Peace and light, everyone, and welcome to today's presentation. My name is Dr. Sonia Fulgham, and in today's presentation, we shall be looking at the most salient aspects of the modules covered during the fall semester of the Masters of Pharmacology for clinical professionals. In this presentation, I shall be taking us through the following course modules in brief, with a focus on their most salient aspects. The first module will entail the medical perspective towards primary care. In the second module, we'll focus shift to the use of psychotropic drugs. The third module is mainly about gastrointestinal and respiratory disorders. Module 4 will be about renal, urological, and cardiovascular disorders, while the fifth module concerns the disorders of the central nervous system as well as the endocrine and metabolic disorders. In the sixth module, the most salient aspects of obstetric and gynecology and rheumatological disorders, and lastly but not least, pain and substance use disorder will be reviewed in the seventh module. There are two major components of the first module, and they are how to develop a medical psychiatric focus intake and dealing with hidden medical disorders, which shall be explained in the next subsequent slides. A medically focused psychiatric intake template is a form that serves as a tool to help us as prescribing psychologists to make a thorough psychiatric assessment of the patient to ensure that we take an efficient and comprehensive approach towards the screening for psychiatric illnesses. Let me take you through the most pertinent aspects of the medical psychiatric focus intake. At the very least, an effective medical psychiatric focus intake shall have sections that source for the following information: the medical history and system reviews of the patient's vital signs, all laboratory and imaging reviews, history of any medications taken, the duration, the dosages, and the response or reaction and effectiveness, family history that could be traceable to the psychiatric issues. Sometimes during your practice, you will encounter situations where a patient presents with symptoms that could be hiding a medical disorder, or the other way around. That is, you may find a situation where the symptoms of the psychiatric issue conceals an existing medical condition. This is termed as masking. The key takeaway points about how psychological problems can mask medical disorders include: with every medical disorder has the potential to trigger stress and manifestation of depressive symptoms in a patient. Such symptoms may be mistaken for a depressive disorder or could also mask as an existing psychiatric issue, which may be attributed to the medical disorder, while in fact, it does actually exist. Bottom line, masking mostly happens when an underlying medical condition has similar symptoms as a psychiatric illness, for instance. A patient with congestive heart failure may exhibit symptoms that meet the DSM 5 criteria for depression, such as weakness and fatigue, significant weight gain or loss, alertness and concentration issues, and nausea and appetite loss. Referring to the medical psychiatric focus intake, working collaboratively with other medical professions and specialist, and familiarizing oneself with the signs and symptoms of other medical conditions could go a long way in unmasking a hidden medical disorder. Like the first module, the second module comprises of two major units. The first unit is about psychotropics and the individual differences. The second unit focuses on doing no harm by making sure that we, the prescribing psychologists, understand the potential adverse drug reactions that could manifest. The pharmacokinetics of a drug is about how it's absorbed from the administration site, its distribution across the body, metabolism, and excretion can significantly influence drug responses, which entail aspects such as the duration and magnitude of the adverse and therapeutic effects of a drug. Individual differences in terms of constitutional factors like disease state, organ functions, or the effect of food and other drugs on an individual all affect the high variability with respect to how different patients respond to different drugs. As a prescribing psychologist, an understanding of the effects that these factors have on the pharmacokinetics of a drug will assist in drug selection as well as adjustment of dosages while within a therapeutic setting that may be further complicated by medical illnesses or polypharmacy. The individual differences are rooted in the following: absorption and bioavailability. On the other hand, drug absorption depends highly on the absorption site characterized and the drug's physicochemical properties. Individual characteristics such as ambient pH surfaces areas, local blood flows, and muscular functions and integrity could affect drug absorption. On the other hand, bioavailability describes the drug delivery magnitude and the rate to the systemic circulation from the formulation. Individuals' focus, such as disease, drugs, and states that changes the hepatic and gut functions, could alter drug bioavailability marked after being absorbed into the systematic circulation. Drug distribution throughout the entire body follows. Notably, the volume of distribution denotes the association between the plasma concentration and the bioavailable dose. As such, individual protein binding mechanisms include disease induced alterations, and affects drug distribution in different individuals. With drug elimination, the principal component are the metabolism and excretion. Notably, the kidney is the primary drug excretion organ, while pulmonary and fecal excretion are not as important. As such, individual metabolic traits and functioning have an impact on both the metabolism and excretion of drugs. Sometimes prescribing and administering psychotropic drugs could result in rare and adverse reactions, even when the best of precautions have been taken. Different adverse drug reactions occur on different places and within different body functions. These include adverse reaction of the central nervous system, cardiovascular reactions, gastrointestinal reactions, renal reactions, and hematological reactions. Although there are some notable takeaways, for example, adverse drug reactions of the central nervous system are quite diverse. However, they have been mostly linked to the use of antidepressant drugs and antipsychotics. Antipsychotics drugs have been associated with arrhythmia and sudden death. Anticonvulsants have been implicated the most in severe hepatic toxicity. Primary, Primarily, severe renal syndromes have been linked to the use of lithium. Several classes of drugs have the capacity to cause the syndrome of inappropriate antidiuretic hormone secretion. Even with these risks of adverse reactions, prescribing psychologists should not withhold prescribing psychotropic drugs because of the risks or the adverse reactions, since most of these drugs are potentially beneficial for a majority of the patients. Careful patients monitoring backing by informed familiarity with adverse symptoms and signs to enable timely recognition, speedy discontinuation of the implemented drug, and in constitutionalization of supportive treatment remains the best defense against adverse drug reactions. In this module, one of the key takeaways is that patients who are diagnosed with gastrointestinal and respiratory disorders can suffer adverse drug outcomes from the use of psychotropic medications more than those without such disorders. Let us begin by highlighting the principal gastrointestinal and respiratory disorders associated with drug use. Orophageal disorders, esophageal disorders, and gastric, intestinal disorders, and liver disorders. Gastrointestinal side effects that are attributed to psychiatric drugs can range from mild, moderate, and transient to severe. The most common ones include nausea and vomiting, diarrhea, and constipation. The diagnosis of many respiratory disorders have been frequently linked to psychiatric symptoms, which can create the need to prescribe psychotropic medications. Altogether, there are several notable clinical takeaways when it comes to respiratory disorders and the use of psychotropics. First, antidepressants have negligible or no effects at all on respiratory status. Nonetheless, antichlorinic antidepressants could yield bronchodilating and functional benefits. Second, avoiding sedating agents within carbon dioxide retainers is generally recommended unless it is really necessary, and in which case, short-acting benzodiazepines that have no active metabolites and prescribing at a low dosage are tolerated the best. Third, polypharmacy includes the risk for respiratory side effects because it contributes towards undesired drug to drug interactions. Fourth, if the drug is known to trigger QTC prolongation, it should be avoided for asthmatic patients and those with chronic obstructive pulmonary disease. So, in the end, the most important concern when it comes to respiratory disorders is to avoid any medications that decrease respiratory drive or affect ventilation adversely. Renal disease, as well as the medications used and the procedures employed for the management of renal and urological disorders, often trigger psychiatric symptoms like cognitive impairment, sleep disorders, anxiety, and depression. Some of the most common psychiatric symptoms amongst patients with renal disease include depression and depressive symptoms, significant anxiety, cognitive dysfunction, sleep disorders, and in most cases, insomnia. Except for anticlerogenic agents for the EPS like benztropine and trihexyphene, whose renal urological adverse effects are urinary retention and urinary hesitation. All the other categories of psychiatry drugs, that is, mood stabilizers, antipsychotics, and antidepressants, including serotonin norepinephrine reuptake inhibitors, tricycline antidepressants, and selective serotonin reuptake inhibitors, have three common renal and urological adverse effects. The adverse effects are hypotonia, psychogenetic polydipsia, and syndromes of inappropriate antidiuretic hormone secretions. Unless specific information is available for dosing of psychotropic drugs in renal failure, clinicians should start patients with two-thirds the dose recommended for patients with normal renal functions. The diagnosis of many respiratory disorders have been frequently linked to psychiatric symptoms, which may necessitate prescribing psychotropic medications. Altogether, there are several notable clinical takeaways when it comes to respiratory disorders and the use of psychotropics. First, antidepressants have negligible or no effects on all respiratory statuses. Secondly, avoiding sedating agents within carbon dioxide retainers is generally recommended unless it is really necessary, and in which case, short acting benzodiazepines that have no acting metabolites prescribed at a low dosage are tolerated best. Third, polypharmacy increases the risk for respiratory side effects because it contributes towards undesired drug to drug interactions. Fourth, if a drug known to trigger QTc prolongations, it should be avoided for asthmatic patients and those with chronic obstructive pulmonary disease. In the end, the most important concern when it comes to respiratory disorders is to avoid any medication that decreases respiratory drive or that which affects ventilation adversely. In this module, there are two major units that are covered. The first unit is about disorders of both the central nervous system and the endocrine and metabolic disorders. And the second unit is about specific focus on the endocrine and the metabolic dysfunctions. The key takeaways from each of these two units is looked at in the next two slides. Numerous patients that have diseases of the central nervous system tend to present with psychiatric disturbances besides their neurological disorders. Disorders of the central nervous system include the following: dementia, stroke, traumatic brain injury, multiple sclerosis, Parkinson's disease, Huntington's disease, and epilepsy. The various neurological disorders feature the following common symptoms and syndromes: apathy, pathological laughter and crying, and sexual disinhibition. On the other hand, the endocrine system disorders are popular for their tendency to manifest psychiatric effects predominantly and their interrelated nature with the nervous system. Although the next slides contain more information about the endocrine and the metabolic dysfunction, the most common disorders that are covered in the unit include diabetes mellitus, thyroid disorder, antidiuretic hormone, pheochromocytoma, reproductive endocrine system disorder, and hypogonadal disorder. In general, correcting an underlying endocrine disorder leads to improved psychiatric symptoms. However, some symptoms may still remain persistent beyond the restoration of the normal serum hormone levels. In such cases, prescribing psychopharmacological agents may be necessary. With endocrine and metabolic dysfunctions, there are three important clinical dimensions to note. The first one is the primary endocrine disorders, and their treatments could aggravate or trigger clinical symptoms by altering the serum hormone levels. Two, psychiatric disorders may play a role in endocrine dysregulation. For instance, depression has been shown to impair glycemic control in diabetes and to worsen insulin resistance. Three, psychiatric medications will, in most cases, endocrine side effects including hypoglycemia, hypoprolactinemia, hyponausea, hypothyroidism, and hyperthyroidism, just to name a few. There are some notable clinical points about endocrine and metabolism dysfunctions. Correcting the underlying hormone excess of the disorder leads to improved psychiatric symptoms in general. Effective psychopharmacological treatment of endocrine and metabolic dysfunctions often require simultaneous or prior correction of the underlying endocrinological disorder. Psychotropic induced endocrinological disorder, such as lithium induced hypothyroidism or neurophagenic diabetes insipida, or antipsychotic induced metabolic syndrome, or hyperprolactinemia, is common. It is therefore important to screen routinely through both lab tests and symptom assessment. The sixth module of the course transverse obstetrician and gynecology as well as rheumatological disorders. There are two units that are covered in this module. The first one reiterates the module title and entails obstetrician and gynecology and rheumatological disorders. However, for the purpose of this presentation, I shall discuss obstetrician and gynecology in the next slide and rheumatological disorders in the slide after, like lactation. The second unit of this module deals with psychotropics in breastfeeding. Although it is a distinctive unit in the module, the issue of psychotropic in lactation is discussed in the second slide under the module and before rheumatological disorders in order to ensure proper flow of information. In women, the course of psychiatric illnesses is in most cases under the modulation of reproductive events such as lactation, pregnancy, menopause, and menstrual cycle. Moreover, physiological changes during the pregnancy period, menopause, and postpartum period could earliest in women. The course of psychiatric illnesses is in most cases under the modulation of reproductive events such as lactation, pregnancy, menopause, and menstrual cycle. Moreover, physiological changes during the pregnancy period, menopause, and postpartum period could easily mimic psychiatric symptoms, in which case it could be considered within a differential diagnosis. Accordingly, I will approach the main clinical takeaways from the section of the unit under the subheadings. The first subheading covers menstruation and carries the following three weighty takeaways. Secondly, psychiatric disorders may play a role in endocrine dysregulation. For instance, depression has been shown to impair glycemic control in diabetes and to worsen insulin resistance. 3. Psychiatric medications will, in most cases, cause endocrine side effects, including hypoglycemia, hyperprolactinemia, hypogonadism, hypothyroidism, and hyperthyroidism, just to name a few. Here are some notable clinical points about endocrine and metabolism dysfunctions. Correcting the underlying hormone excess of disorders leads to important psychiatric symptoms in general. Effective psychopharmacological treatment of endocrine and metabolic dysfunctions often require simultaneous or prior correction of the underlying endocrinological disorder. And psychotropic induced endocrinological dysfunctions, such as lithium induced hypothyroidism or nephrogenic diabetes insipida, and antipsychotic induced metabolic syndrome or hypoprolactinemia is common. It is therefore important to screen it routinely, though both labs and symptom assessments. In lactating mothers, one of the biggest challenges that prescribing psychologists and clinicians are bound to face in their practice is the issue of balancing the benefits that a mother is likely to occur from the use of psychotropic drugs and treating their mental health issues and protecting the infant from the risks that are associated with the use of such psychotropic drugs by the mother. Altogether, the following clinical points are important to note. First, every psychotropic drug that is available in the market and is prescribed to the mother has the potential to be exposed to the infant. Secondly, the level of risk of the infant exposed when the mother is using psychotropic drugs is lower than in utero. The only expectations in this case are lamotrigine, lithium, and carbazepine. Third, most of the available data supports that paroxetine and sertraline are safe for the use of lactating mothers. As much as possible, it is important to avoid all antipsychotics despite the safety levels associated with some of them. The mood stabilizer, gabapentin, because it has been shown to pass 100% into breast milk, and the two analytic, zyplicone and zypolipin, because there is very little data about them and their high risk of infant sedation effects. In the U.S., the Food and Drug Authority has provided guidelines that categorize psychotropics into five categories, depending on the risks that they pose to the infant during breastfeeding and the availability of the data of the drug. These categories, which can be viewed from the FDA MedWatch program online, and their meanings are L1, which are considered to be the safest for the use of lactating mothers. L2, which are said to be safe, but the studies support such safety outcomes include a limited number of breastfeeding mothers. L3, psychotropics are considered moderately safe. When it comes to the L4 category, there are considerations to be potentially hazardous. Finally, L5 psychotropic drugs are counterindicated, which means that there is significant documentation that there are risks to the infant. They carry significantly high risk of causing damage to the infant, and that using them has a higher risk for the infant than benefits for the mother. Patients with rheumatological disorders often present with neuropsychotic disorders too. The following are the silent aspects concerning rheumatological disorders. First, the differential diagnosis of psychiatric disorders in patients suffering from rheumatological disorders include the following: primary psychiatric disorders, secondary syndromes such as psychosis from central nervous system lupus, and side effects that are attributable to the use of rheumatological medications. Second, patients that have been diagnosed with rheumatological disorders have a high prevalence of depression. Third, evidence from categorized controlled trial studies show that antidepressants are effective in treating depression in patients that have been diagnosed with rheumatoid arthritis. Amongst all of the drugs that are used in treating rheumatological disorders, corticosteroids show the highest likelihood of causing psychiatric side effects. Pain is probably the most common symptom that causes people to seek medical treatment. In pain management, a comparatively small number of cases of drugs apart from opiates are used for treating chronic pain and particularly neuropathic pain conditions. As the last module of this course, pain and substance use disorders was the only principal unit besides the aspects of bringing it all together in capstones. The most salient aspect of these units revolve around medical selections. It is important to determine the functional outcomes before commencing therapy. Serotonin and norepinephrine reuptake inhibitors, and tricyclines are the first line therapies for pain management. Anticonvulsants are considered second line therapies. Atypical antipsychotics and opioids are third line therapies. And whenever possible, serum levels should be optimized. Different combinations of medications are likely to cause an increase in the anergic effects. Combining an antidepressant with an atypical antipsychotic with two anticonvulsants where the second one has different mechanisms, and combining an antidepressant with a mood stabilizer anticonvulsant. When it comes to pain and substance disorder, it is important to take caution as the following. Since the major depressive disorder is often underdiagnosed and undertreated, it is important to treat the patient aggressively in the event of persistent disabling pain. Secondly, opioids should be avoided when a patient has been diagnosed with major depressive disorder. Similarly, short-acting pain medications should also be avoided for patients with major depressive disorder. If there has been two consecutive increases of dosages of opioids without any notable benefits, then the dosage should be increased. It should not be increased any further. Finally, SSRIs should not be avoided in pain management because they are utility. And now, ladies and gentlemen, before completing my presentation, let me share with you the following important parting shots. First, there is no substitute for conducting proper and comprehensive psychiatric assessments of patients presented to you as a prescribing psychologist. This will give you a better understanding of the underlying issue and the ability to isolate such phenomena as masking. The use of psychotropic drugs for the treatment of different psychiatric issues must be done in consideration of any underlying conditions such as respiratory or cardiovascular, renal, urological, and endocrine and metabolic syndrome, amongst others. Different categories of individuals require different interventions. For example, pregnant and breastfeeding mothers require special considerations while devising treatment interventions or adjustments of the existing ones. Whenever treatment interventions one is devising or adjusting, its benefits must always outweigh the risks and adverse reactions associated with treatment interventions in question. So I want to take the time out to tell you thank you, and you guys have been such a wonderful audience. Thank you. Have an amazing day on purpose and continue to be great. Peace and light.